Welcome back to Cardiology, Part 4, Arrhythmias. This one is all about reading the ECG. We cover the atrial rhythms, the AV blocks, preexcitation, the dangerous ventricular tachycardias, and the potassium tracings. Let's read some strips. We start in the atria. Both are fast atrial rhythms, but the baseline tells them apart. Organized sawtooth waves or chaos with no real P waves. Atrial flutter is an organized re-entry circuit. The baseline shows sawtooth flutter waves, best seen in the inferior leads, at an atrial rate around 300, and because conduction is often a fixed ratio, the ventricular rhythm is usually regular. Atrial fibrillation is disorganized. There are no discrete P waves, just a wavy baseline, and the ventricular response is irregularly irregular. Both raise stroke risk and need anticoagulation. So sawtooth waves with a regular rhythm is flutter, while no P waves and an irregularly irregular rhythm is fibrillation. Now second degree AV block. The whole game is the PR interval before a beat drops. Does it stretch out first or stay rock steady? In Mobitz I or Wenckebach, the PR interval lengthens beat by beat until a QRS is dropped, giving grouped beating. The block is in the AV node and it is usually benign. In Mobitz II, the PR interval stays fixed and then a QRS suddenly drops with no warning. The block is below the node, the QRS is often wide, and it tends to progress to complete heart block, so it needs a pacemaker. So a lengthening PR before the drop is Wenckebach, while a fixed PR with a sudden drop is Mobitz II. Let's zoom out to the whole spectrum of AV block, from a harmless delay to a complete disconnect. Which ones can you watch and which ones need a pacemaker? The lower grade blocks are benign. First degree block is a PR interval over 200 milliseconds where every beat still conducts. Mobitz I, Wenckebach, lengthens the PR until a beat drops. Both live in the AV node and are often from vagal tone or rate slowing drugs like beta blockers, calcium channel blockers, and digoxin. The high grade blocks are dangerous. Mobitz II has a fixed PR with sudden dropped beats, and third degree or complete block has total AV dissociation, where the P waves and the QRS complexes march independently. High grade block needs pacing, so first degree and Wenckebach you watch, while Mobitz II and complete block you pace. Wolff-Parkinson-White, or WPW. There is the harmless baseline pattern, and there is the dangerous version when atrial fibrillation meets the accessory pathway, where the usual rate-control drugs can be deadly. The WPW pattern is baseline preexcitation. An accessory pathway lets the atrial impulse bypass the AV node, giving a short PR interval, a slurred delta wave, and a widened QRS, and most people are asymptomatic. The danger is when atrial fibrillation develops in a WPW patient. The chaotic atrial impulses race down the accessory pathway, producing an irregular, very fast, wide complex tachycardia. Here is the trap. AV nodal blockers like adenosine, calcium channel blockers, and digoxin can push even more conduction down the pathway and trigger ventricular fibrillation, so you avoid them and use procainamide or cardioversion. So a delta wave at baseline is the pattern, while an irregular, wide, fast tachycardia is pre-excited atrial fibrillation. Polymorphic ventricular tachycardia, the QRS twisting around the baseline. Whether you call it Torsades comes down to one measurement on the resting strip. Torsades de Pointes is a polymorphic ventricular tachycardia where the QRS amplitude twists around the baseline, and the defining feature is a prolonged QT interval on the underlying rhythm from QT prolonging drugs, low potassium or magnesium, or a congenital long QT syndrome. The treatment is intravenous magnesium. If the QT is normal, a polymorphic VT is usually driven by acute ischemia, is not called Torsades, and you treat the ischemia. So polymorphic VT with a long QT is Torsades, while a normal QT points to ischemia. Finally, the potassium tracings, a guaranteed exam favorite. High potassium and low potassium each leave a signature on the ECG. Hyperkalemia starts with tall, peaked T waves, and as it worsens, the P waves flatten and disappear, the QRS widens, and finally you get a sine wave rhythm and a rest. Think kidney failure, potassium-sparing drugs, and acidosis. Hypokalemia does almost the opposite. The T waves flatten, prominent U waves appear after the T wave, there is ST depression, and the QT interval looks long. Think diuretics, vomiting, and diarrhea. So peak T waves mean high potassium, while flat T waves with U waves mean low potassium. Lock it in. Atrial rhythms, sawtooth and regular is flutter, no P waves, and irregularly irregular is fibrillation. Second degree block, a lengthening PR before the drop is Wenckebach. A fixed PR with a sudden drop is Mobitz II. And across the spectrum, first degree and Wenckebach you watch, while Mobitz II and complete heart block you pace. A delta wave at baseline is the WPW pattern, while an irregular wide fast tachycardia is atrial fibrillation with WPW, where you avoid AV nodal blockers. A polymorphic ventricular tachycardia with a long QT is Torsades, treated with magnesium. And on the potassium strips, peaked T waves mean high potassium, while flat T waves with U waves mean low potassium. That is part 4. Part 5 covers the congenital heart defects. See you there.